If you'd like to turn off the captions, you can just hover over the CC closed captions icon to turn off the running transcript. We'll have about 35 minutes for Kavita's presentation, and then we'll have 10 to 15 minutes or so for a general audience discussion. And as usual for this year, we'll wrap up with 10 to 15 minutes for Kavita to meet with our trainees in the pre-doc and postdoc program to have a chance to talk with her about her career path. So, those are the general housekeeping things I wanted to clear out of the way. And so I'll begin now with an introduction of Kavita. She is an associate professor in the Department of Maternal and Child Health at the University of North Carolina, and also a faculty fellow at the Carolina Population Center. She holds a PhD from the Department of Population Dynamics at the Johns Hopkins Bloomberg School of Hygiene and Public Health. Her current work is focused on methods to obtain data on hard to measure outcomes, such as maternal mortality, and techniques to improve the quality and use of health facility data. So we're particularly eager to have her here at ISR, where we think a lot about data collection and data quality. She's strongly interested in translating pilot phase evaluation findings to effectively scale up and adapt methodologies to broadly improve data on maternal, child, and newborn health outcomes. She has served as the senior technical advisor on major international programs to improve data collection and data quality in health systems around the globe, including the USAID-funded Measure Evaluation Project and Data for Impact Project. She's also been PI or evaluator on a variety of health service quality improvement evaluations in Africa, including projects in Ghana, Ethiopia, and Malawi. Today, we're very pleased to welcome Kavita to discuss her research and evaluation work on programs to help newborns survive and thrive in low resource settings. So I will turn things over to you now if you're ready to go.
Okay, thanks so much, Paula, for that introduction. Also wanted to thank Sarah for the invitation to come present today, and Lakeisha for all her assistance with getting ready for the presentation as well. It's really nice to be able to talk to all of you today. So I'll be talking about some projects I've worked on in Ghana and Ethiopia that have focused on helping mothers and newborns survive using quality improvement approaches. So I like to start this presentation with the human rights angle. The Universal Declaration of Human Rights actually states that motherhood and childhood are entitled to special care and assistance. But unfortunately, we know that millions of mothers and children around the world are not getting that special care and assistance. Many mothers have difficulty accessing high quality maternal health care. And this is so important because even though the majority of pregnancies proceed normally, in about 15% of pregnancies, there is a complication, and some of these complications can be fatal if not treated quickly. So we need all women to have access to high quality care. And then for children under 5, they have the highest mortality of any age group except the very elderly. Children under 5 are particularly vulnerable to infectious diseases and undernutrition. They're also dependent on other people to take care of them, and they can't advocate for themselves. In terms of the magnitude of the issue, the most recent estimates indicate that there were 5.3 million deaths to children under 5. And of those 5.3 million deaths, 2.4 million occurred in the very first month of life, the neonatal period. And if we were to break that data down further, we would see about half of those 2.4 million neonatal deaths occurred in the very first week of life, and a high proportion occur on the very first day of life. So the first day and week and month of life are a particularly vulnerable time period for an individual. So globally, we need to do better in helping newborns survive. And for maternal health, we've had about 295,000 deaths to mothers around the world. And what is most tragic about these numbers is that the majority of under 5 and maternal deaths could have been prevented with known interventions. So often it's not that we don't know what to do, it's that we're not getting high quality interventions to vulnerable mothers and children. So globally, there's been a big focus on improving access to care, helping mothers and children access care. There are many reasons why there are barriers to care. Some of the barriers include poverty, being marginalized or discriminated against, conflict. There could also be geographic barriers in terms of distance to health facilities. Other barriers, might include knowledge of when a complication is very risky and when it warrants immediate care. And then on the other hand, we also have to improve the quality of care, because it's not enough just to provide care. It has to be at sufficient quality in terms of making sure the health workers are trained and the health facility has all the medical equipment and medications needed to save the lives of mothers and newborns. So globally, we've seen a lot of focus on quality improvement, which is sometimes defined as strategies to improve the delivery of effective interventions. So I have had opportunities to work on evaluations of quality improvement projects. One was in Ghana and another was in Ethiopia. So in Ghana, the project was called Project Fives Alive, and it aimed to assist and accelerate Ghana's efforts to achieve MDG 4, which was focused on reducing under 5 mortality, and MDG 5, which was focused on reducing maternal mortality through the applications of QI methods. That project ran from 2008 to 2015. It was implemented by the government of Ghana, so this included the Ghana Health Service, also the National Catholic Health Service of Ghana, and these two agencies received technical support from the Institute for Healthcare Improvement, which is an organization based in Boston. And UNC was part of the evaluation team along with the University of Ghana. We worked together as an external evaluation team. And then in Ethiopia, the aim of the project was a national reduction in maternal and neonatal mortality over a 30-month period. So they were aiming for about a 30% reduction. That project ran from 2016 to 2018, and it was also implemented by the government. So the main implementing partner was the Federal Ministry of Health of Ethiopia, and they also received technical assistance from the Institute for Healthcare and Improvement. And the external evaluation team was Addis Ababa University and also UNC Chapel Hill. So it's definitely important to evaluate quality improvement projects in different settings. Each setting is very different. And quality improvement initiatives were initially implemented in high-income countries, and more recently they've been implemented in low and middle-income countries. So it's important to understand how they work in different settings and what are facilitators and barriers. So just pointing out that Ghana and Ethiopia, both in Africa, but very different countries. Ghana is located in West Africa, has a population of about 28 million. Ethiopia is in East Africa, has a much larger population at over 100 million people. In terms of area, again, Ethiopia is much larger. Ghana, as of 2011, has been classified as a middle-income country, while Ethiopia is classified as a low-income country according to the World Bank. And then in terms of maternal mortality, both countries do have high maternal mortality. It is a bit higher in Ethiopia. And then in terms of under 5 mortality and neonatal mortality, the rates are similar. So both countries were very much interested in applying quality improvement methods to attempt to achieve reductions in maternal and under 5 mortality, including neonatal mortality, and overall improving the quality of care provided to mothers and children. Both projects used what's called the model for improvement as their underlying theory. With this model, quality improvement teams are formed at the level of a health facility, and these teams or sometimes at the level of a small geographic unit like a subdistrict. So in the case of Ghana and Ethiopia, some facilities, larger facilities like hospitals, had their own quality improvement team, but in some other geographic areas, health posts might join a health center to form a team. And health posts are at the first tier of health provision, health centers are at the second tier, and hospitals are at the third tier. So these teams would come together. They would receive training in quality improvement methods during what was called learning sessions. So they would receive this training on how to use quality improvement approaches within their own work. And then they would go back to their own health facilities and use what are called plan, do, study, act cycles to identify within the context of their own facility barriers to the provision of high quality care. And also they would think about barriers in terms of the community being able to access care. And then they would think about simple, low cost ideas. They call these change ideas that could potentially improve or eliminate that barrier and help improve health outcomes. So they would test out these change ideas in the study part of the cycle. And then they would also look at their own facility data at the local level to look at whether after implementing this change idea, whether there have been any changes in actual outcomes. And if so, they might make that change idea part of routine care, something that they would do for all women and children. So this process is driven by people on the front line, so very much driven by local health staff who are well equipped to understand key barriers to the provision of high quality care and who have good rapport and would be knowledgeable about the communities that they serve. So these are some examples of change ideas for the first tier of health facility health posts, which were typically staffed by community health workers and health centers. So that's at the second tier. These health centers sometimes were staffed by community health nurses, and some of them, but most of them did not, but some of them had midwives who could actually do deliveries. So some examples of the ideas that these teams came up with, kind of categorized them here into early pregnancy identification. So these are ideas that would help women come in early for antenatal care. So some ideas that they tested were community stakeholder meetings on the importance of early antenatal care, getting pregnant women registered early in their pregnancy by community health volunteers was another change idea. And then for 4A and C visits, some of the ideas were increasing the number of days that antenatal care is offered at the facility. So trying to make it more accessible to more women. Also, they found that a lot of women couldn't always come in for antenatal care visits because they felt like they'd have to wait the whole day, spend hours at the facility. So some of the teams focused on reducing visit time duration, also offering antenatal care as an outreach service. So not always that the women had to come to the facility. Sometimes the health workers or the community health volunteers would go out into homes to do antenatal care as outreach. And then some facilities did antenatal care defaulter tracing, meaning if a woman came for the first and second visit but missed her third visit, they might call her if she provided a cell phone number or go and visit her to make sure she was doing okay. And then in terms of skilled delivery, some teams started using partographs, which is just a simple tool to help monitor the progress of labor. It helps a health worker know if labor is becoming prolonged and whether action is needed. In some facilities, midwives provided their phone number to pregnant women. And this was important because a lot of times in the rural areas of these countries, it's very hard to get to a health facility. Sometimes the nearest health facility that could provide delivery services might be very far away. And we know that a lot of babies like to come at nighttime when there are few people around and very few transport options. So sometimes the midwives would be able to call their health facility to see if that facility could send transport to come and pick up the laboring woman. And then in terms of postnatal care, so both these projects had a big focus on both improving maternal health and also newborn health. So some ideas were focused on this idea of postnatal care. And postnatal care on day 1 and day 2 is that immediate postnatal care soon after delivery. So in some teams, they decided to make sure women stayed at least at a minimum of 6 hours and up to 48 hours after delivery so that they could do postnatal checks for both the mother and the newborn. Other facilities decided to do home visits, knowing that in a lot of cases it was hard for the women to come back to the health facility with their newborn. And they also did home PNC visits for women who delivered at home. And then postnatal care, day 6 or 7, some facilities encouraged women to make a follow-up visit on day 6 or 7 after delivery. Other facilities did the home visits, and there was also defaulter tracing. So we know a lot of maternal and newborn mortality occurs in that first day or so after delivery or the first week. So postnatal care has a lot of potential to help mothers and newborn, and it has potential to reduce maternal and newborn mortality. And then for hospitals, so hospitals generally have a different patient load, patients who might be sicker or who might have been referred from a health post or a health center. So the patient load is very different. They tend to be more crowded and have more patients. So the ideas that they were testing here were a little different. One idea was focused on timely care seeking. So we know with both maternal and under 5 mortality, delay in seeking care can make a case more complicated to treat or make it much harder to treat. And some diseases and complications like hemorrhage for maternal health, hemorrhage can be fatal if not treated in hours. So early care seeking was a big focus for a lot of the hospitals. So engaging with communities on the importance of early care seeking and knowing what is a severe complication, when should care be sought. Another idea was prompt provision of care. So in some of these settings, hospitals, like I said, would be very crowded, have a lot of patients every day. So many of the teams decided to triage, especially triaging children away from adults. So having totally separate triage for children, and then being able to triage for sick children who really needed prompt care. So trying to assess the severity of an individual's condition and knowing how to triage appropriately. And then in terms of adherence to protocols, training staff on regular protocols for different diseases was tested out by a lot of the facilities, a lot of the hospitals. And I should point out, in a lot of hospitals, particularly in the rural districts, sometimes they'd only have one doctor in charge of the whole hospital, and that person cannot be everywhere at once. So many teams focused on empowering nurses to begin treatment protocols before the doctor arrived. So that's also very much tied to early provision of care. And then in Ethiopia, some of the hospitals used checklist or bundles. So a set of interventions that they would do for admission during the laboring phase and after birth. So making sure each woman is being checked for certain things and getting a set of interventions during her visit. And then this is a graphic kind of showing how the project in Ghana started with a pilot phase and ended with a national scale-up phase. So the project first started with a startup phase, getting everything ready, training the quality improvement staff, the project staff, and working with the government of Ghana on the project. And then the launch was in July 2008 with what was called Wave 1. So this was a small pilot phase with 27 health facilities in the north of the country. The project decided to start in the north because the north had higher maternal and under 5 mortality than the southern regions. And then wave 2 was a big scale up to all of the health facilities in all of the north. And then wave 3 started with 29 hospitals in the south. And then wave 4 was a big scale up to all district and regional hospitals in the south. So over time, this was a very big scale up over the years from a small pilot phase to a national scale up phase. And then in Ethiopia, there was a similar approach, but again, Ethiopia is a much larger country. So they had a they had a pilot phase where it started with 5 waridas or districts in 3 different regions. So that was a total of 160 facilities. And then the project had what's called a test of scale-up phase. So because Ethiopia is a very large and diverse country, they wanted to do a test of scale-up phase before getting into the full scale-up phase. So in the test of scale-up phase, they expanded to 21 waridas, including the original 5, in 5 different regions of the country for a total of 650 facilities. And then later on, there was a follow-up project, which actually is still ongoing right now, which is the full scale-up phase to all 11 regions of Ethiopia. So some key evaluation questions that we were working with the implementing team to answer were what improvements and outcomes occurred due to this intervention. The implementing team wanted to know, can the change package that they developed be linked to actual improvements in maternal and child health outcomes? And then they wanted to know what are the facilitators and barriers to these improvements. And the second question they were interested in is how does the project contribute to knowledge and skills of the participants, particularly these QI teams? And then in terms of experience, what are the participants' experiences of engaging in the project? And this included the patients, providers, and managers and leaders at the health facilities. So to answer all of these questions, we needed to use a mixed methods approach. So a lot of different questions were important, and quality improvement projects are also complex and warrant different methodologies to really explore different evaluation questions. So in both Ghana and Ethiopia, we had an impact analysis. We weren't able to have comparison facilities for either Ghana or Ethiopia because they were national scale-up projects, and there were some issues with data quality at facilities that were not yet part of the intervention. We also did some team assessments, asking questions about knowledge, team functioning, and team achievement to QI team members. In Ghana, we did qualitative assessments on community engagement and team functioning and achievement. In Ethiopia, our qualitative assessments were focused on mothers' perceptions of the quality of care they were receiving and their satisfaction with services that they were receiving. In both countries, we did a cost effectiveness analysis, and in that analysis, we were comparing different phases of the project to one another. So for example, in Ghana, we compared the pilot phase in the north to the scale-up phase in the north to see if one was more cost-effective than the other. And in Ghana, we also had the opportunity to do household surveys, exit interviews, and provider surveys as well. So because that's a lot of different methods, I'm only going to focus and give a brief overview of the impact analyses in Ghana and the qualitative assessments in Ghana. So in Ghana, we used pre and post intervention means and multivariable time series analyses for our impact analysis. Our key outcomes were under 5 mortality, neonatal mortality, skilled delivery, whether women were delivering with the help of a skilled birth attendant. We were looking at whether or how many women were getting 4 antenatal care visits, which at the time was the standard of care. Now I believe the standard has increased to 8 visits, but at the time it was 4. And we also looked at underweight infants attending child wellness clinics. Then our key independent variables were the change categories that were tested. So we really wanted to know if this locally driven change ideas could actually result in impact and change in outcomes. So we aggregated all data for all facilities for different waves of the project, while the QI teams on the ground were only looking at data for their own facility. So ours was looking at aggregate data to look at overall impact. We also looked at intensity, whether doing more changes resulted in more improvements or not. And then we had some other key programmatic and facility level variables that we were studying, including type of health facility, whether it was a health post, health center, or hospital. Affiliation of the health facility was important in Ghana. Some facilities were public and others were faith-based. Catchment population of the health facility, number of supervisory visits by project staff, profession of the QI team leader, and project officer assigned to work with the team. So we're looking at different factors that were important to implementation. Our key equation is shown at the bottom, where basically we're looking at change idea over time. So we're looking at facility data. For each facility, we had several months of outcome data. And then our key terms were beta 2 and beta 3, with beta 2 showing us the immediate impact of testing out a change, and beta 3 reflecting what's happening after that change over time. What's the trend in the outcome over time? So this is just a graph showing a plot of some of our outcome data over time. And this saturation point is when the point at which the teams had enough training that the project felt we should start seeing some evidence of change in the outcomes. So over time, so in red is the skill delivery outcome over time. In blue is the percent of underweight infants attending child wellness clinics, and the green is the early ANC. We didn't have a lot of data for early ANC. It was a newer outcome that Ghana started to collect after the project began. And so then in terms of some key findings for wave 1, so wave 1 is the pilot phase in the north. It included 27 health facilities, 25 health centers, and 2 hospitals. And the time period was 18 months. So this was the pilot phase. We found that postnatal care changes were associated with higher rates of visits by underweight infants to child wellness clinics. This could be because part of postnatal care is doing some checks on the mother and newborn, but part of it is also providing health information. So providing health information on the importance of follow-up visits, particularly for low birth weight and preterm infants. And then we found that the early pregnancy identification change was associated with increased skilled delivery. And we see that in the literature a lot, that women who come in for antenatal care, particularly those who come earlier for more visits, are more likely to have a skilled delivery. So it could be part of it is getting rapport with the health workers and getting to be part of the health system early on in pregnancy increases confidence with having a skilled delivery at a health facility. And we found that doing more change ideas was associated with skilled delivery. And then for the wave 2 findings, so wave 2 again was the scale up phase to all health facilities in the north. So we had a total of 744 facilities, and it was a much longer period, 43 months of time. We were able to stratify by facility type because we had a large number of hospitals, health posts, and health centers. So we found that 3 of 5 change categories were associated with increased skill delivery. And so this differed by whether it was a health post or whether it was a hospital. So again, the hospitals were testing out different change ideas. We found that postnatal care was significantly associated with greater attendance of underweight infants at child wellness clinics. That was for both health posts and health centers. For hospitals, we found the triage change category was associated with increased early antenatal care in the hospitals. And then intensity, doing more change ideas, was associated with increased skill delivery in health centers. And actually we found reduced under 5 mortality in hospitals. So there was actually an effect on under 5 mortality. In wave 2, I should point out, we weren't able to look at neonatal mortality because not enough of the hospitals were reporting neonatal mortality during this time period. So some key points. So I just want to point out these 2 project phases were very different. Wave 1 was a pilot phase. It had a heavy programmatic touch, meaning project staff spent a lot of time with each of the QI teams. While in wave 2, with this large expansion to 744 health facilities, more of the supervisory activities were turned over to the government. So between wave 1 and wave 2, the Project Fives Alive staff didn't increase very much. It's not like they hired a lot of new people. The approach was different. Wave 1 having that heavier programmatic touch, and wave 2 handing more activities over to the government. So wave 1 was important in demonstrating proof of concept. It was a short time period, so you could learn from it and use findings to adjust, make a programmatic adjustments for the larger scale-up phase. And wave 2 was more reflective of potential sustainability, because once the project ends, the idea was that the government would take over these quality improvement activities. So wave 2 also had this longer time frame and more facilities. So we had more time and more power to see changes in mortality. We didn't see any impact from wave 1. And sometimes it's because you need more time to see changes in mortality. And with wave 2, we were actually able to do the stratified analysis. And this is important because quality improvement may be different and have different potential impacts depending on the type of health facility. I'll just give some brief summary of some of our findings from the qualitative assessment. So the purpose of this was to understand how community outreach strategies were integrated within QI processes at the health facilities. So we used a case study approach. We had 9 teams in the north and 3 teams in the south of Ghana. We did individual interviews with team members and observations on capacity to provide different maternal and child health services. We used narrative and thematic techniques for our analyses. And we found that QI team members used 2 distinct outreach approaches. One was community level outreach, which included health promotion and education efforts through group activities and mass media communication. And another was direct outreach. So this was more one-on-one personal information exchange with health workers and with patients. So more one-on-one counseling, making sure women were comfortable in answering their questions. So this is a quote for an example of community outreach. This quote comes from a community health nurse talking about, we called our chiefs, we sat down with them, and then we asked them to choose some particular community that was not coming early to register. So we had about 5 communities out of the 12, and we were able to take care of them. We went from the different communities to sit with the chiefs again to see how best they can take care of these women who failed to come to register. So this nurse was talking about early registration for antenatal care and the importance of engaging communities, engaging chiefs on the purpose and reasons for why is antenatal care important, and getting their support and buy-in. And this is a quote about direct outreach. And also home visits. We increased their home visits, and also we try to do defaulter tracing visit with women who fail to return to the health facility for a follow-up visit. We try to correct mothers who don't come for weigh-in sessions and tell them what their weigh-in session is for, like the importance of child wellness clinic or antenatal care. So this is more one-on-one, trying to inform women about why this is important, why is it helpful for them or for their child. The qualitative assessment also revealed some barriers that some teams found with outreach, and some teams found structural and geographic barriers. These include things like impassable rivers in some of the rural communities, or lack of fuel to do outreach. Like maybe they wanted to go to a community that was quite far from the health facility, but they didn't have the support or the fuel to get there. Some communities, there might have been cultural barriers. In some cultures, women do not disclose pregnancy until the second trimester, or newborns are kept at home for the first week. But these teams found that home visits were acceptable. Other barriers were with the teams themselves. This could include poor dynamics within the team. Individuals from different health facilities might be far away geographically, so sometimes it was hard for them to meet. And then staff turnover was an issue for some of the teams. And then in terms of facilitators to outreach, some teams worked with communities on emergency transportation plans. So they would sit down with communities on thinking of, how could they get women and sick children to a health facility on an emergency basis. So one community mentioned that the local church had a pickup truck. So this community engaged that church to ask if that truck could be used, in situations of emergencies. In terms of cultural barriers, the teams worked closely with the communities to find culturally respectful solutions, like the home-based postnatal care visits. In terms of team barriers, members indicated that it was very important to share quality improvement information with new members and to share information with other teams. So when they would go for quality improvement training, to spend time talking to other teams and sharing some of the change ideas that they came up with and barriers and solutions that they came up with. So just to summarize, quality improvement methods have the potential to improve maternal and child health outcomes in low resource settings. We definitely found some evidence of impact on some key maternal and child health outcomes from our evaluation work. So local health workers and staff are best able to identify barriers and solutions. Engaging the community is a key aspect of the intervention. And given the complex nature of quality improvement interventions, mixed methods evaluations are needed. It's important to do these evaluations in different settings, because each setting is unique, to understand how interventions can best work in different interventions, and to share that knowledge is important. It's also important to think about both pilot and scale-up phases. Often they have different programmatic touches. So evaluating both pilot and scale-up phases is important because actually they're quite different. Often scale-up phases are less programmatically intense and rely more on, like in this example of Ghana, more on the government to take over some of the activities. So that was just kind of a quick summary of some of the quality improvement work I've had a chance to be part of. I'm happy to take any questions at this time.
Okay, thanks so much. Looks like Barbara has a question.
Thank you. That was very interesting, and it will be exciting to hear the results of further analysis. But I had a question. As I understood it from your quantitative analysis model, I didn't see that you included any characteristics of the women, like their education or their age or the distance to the health facility. Did I hear that right? And why did you do that?
So actually, we were looking at aggregated facility data. So like all the records at a health facility were aggregated into one number. So a facility like for the month of January, like say for skilled delivery, we'd find that for that catchment population, 65% of women delivered with a skilled birth attendant. So we didn't have any access to individual records. So this was done all at the aggregate level.
Is that something that you couldn't get access to, or was it a question of time and people to analyze it? Could you go and look at this on the basis of individuals?
So I think the like the implementing team really wanted us to focus at the aggregate level because there's a lot of information on individual factors and their impact on maternal and child health outcomes, but they really wanted to get at the impact of the intervention itself at the aggregate level.
Well, and I'll shut up in a second, but that makes sense. But sure, we know a lot about from studies of individual characteristics related to that. But I don't think we know quite as much in terms of responsiveness by things like education and age and distance to the effect of these interventions. And it seems like you'd have to decide whether it's worth it and whether you could access it or not. But I don't think you wouldn't learn, I think you would learn additional things by incorporating those kind of variables.
Yeah, distance is very important. We tried to get information on distance, but again, since this was aggregate, distance would vary for individual women.
Which is why it would be helpful to have individual data, excuse me.
Yeah, so this was all facility level monthly data that was aggregated for all women or children. So we didn't have access to any individual records.
Thank you.
Yeah.
I have a question from James Allen. We still can't hear you, James, even though you're unmuted.
Oh.
How about now?
Yep,
Yeah.
good.
Sorry about that. My apologies. Thank you for the great presentation. Thanks for calling
Oh,
my
thanks. Okay.
I was a Peace Corps volunteer in Mali, hence my Malian art.
Oh, beautiful art.
And saw a lot of these issues in rural communities kind of firsthand, and I'm very passionate about it. I study development economics now. I look forward to chatting more about the process a little bit later as a training.
Sure, yeah.
My question, I guess, was, and I may have missed this because I was maybe taking care of my own newborn a little bit.
Oh, okay. That's important.
There a community level control group in this? Because it seemed like we were comparing different aggregate level facilities to other facilities who were doing it. And where I thought the talk was going, what I was excited for, and maybe this is something that was done that you could elaborate on, but it seemed like this is proposing like a decentralized type of intervention. So rather than like me, Mr. Development Economist, coming in and saying, this works for everybody, and whatever, what we're actually promoting is that everyone comes up with their own solutions. Were you able to compare that strategy to facilities where that strategy was not implemented?
That's a really good question. Thank you. So we were not able to have comparison facilities. So with the time series analysis, each facility kind of served as its own control pre and post. But the reasons we weren't able to get comparison facilities, the government of Ghana was really worried about the quality of data, like the intervention itself, because the teams were looking at data. So it was automatically improving the quality of the data by being used. You know, when you're using the data, you're going to pay more attention to it. So they were worried that the comparison facilities would have poorer quality data and that it wouldn't be an appropriate comparison. But we asked them quite a bit about it, and we had a lot of discussions about it. But in the end, we just agreed with them that maybe it would not be a good idea because, and particularly with mortality outcomes, you might expect mortality to actually increase as the quality of data is improving, because a lot of the health facilities were maybe scared to report mortality data. They fear that they're being blamed. And so you might actually find that it actually for a time increases as you're improving the quality of data, and then maybe later it might stabilize. So that was another concern that they had.
Yeah, that's there's some really interesting data collection issues. So we'll look forward to talking to you more. Thanks.
Okay, thanks so much. Yeah.
Cheryl, Moyer?
Hi, Cheryl.
Hi, Kavita. Great
Hi.
talk. So it's so great to hear about your work verbally. I've read so much.
Oh.
This was a Herculean effort. When I look at the amount of data that you collected and the number of facilities that are covered, I mean, a Herculean effort. So first,
There's a lot of data. It's a lot of data.
Huge kudos, because I
Okay.
can't imagine the logistics. So take this with a huge grain of salt.
Okay. Okay.
We've done some work in the north that was after 2015. It was 2015 through 2017. And one of the things that we find is that there are many, and this is around maternal and newborn mortality. There's a lot of facilities that send moms and babies home and then they die at home. So that's a missing data point in the evaluation.
Yeah.
And that's the piece that, don't get me wrong, I mean, I know the limitations of DIMS data. I assume this was using the DIMS data that are aggregated at the facility level.
Yes, it was data. Yeah.
Yeah. So I know the limitations of DIMS data, and I know there's only so much you can do, but I'd love for you to speak a little bit about how looking at it at a facility level may miss some other pieces of data that are out there.
That's another great point, because a lot of maternal and under 5 deaths can occur at home. So we worked with the government of Ghana, trying to see if there was a way to get community level data, and they did have some community level reporting, but it was inconsistent across the different communities. So we couldn't use it for some communities and not others. It wouldn't make sense. So that is definitely a limitation of looking at mortality only with facility level data. So that definitely is a good point. We did look at other outcomes as well, knowing that, we can't just restrict ourselves to mortality. So that's why the skilled delivery was so important in antenatal care. But definitely there's challenges with using health facility data in terms of, thinking about the quality, and underreporting of mortality definitely are key issues. Hi, Sarah. Yeah.
Hi, it was really great to hear this talk, and I'm so excited to have an MCH talk this early in the year, and some great ones on the lineup this year. So thanks so much for, yes, this incredible effort to collect and analyze data, and data that is so fundamental to demographic research. So I really appreciate it. My question was a little bit different. I am curious whether you got any feedback from the qualitative or otherwise collection of information from the quality improvement teams or other folks on whether you saw that what we're talking about here is mainly average effects at the clinic or facility level. But I was wondering if you saw any evidence of differential effects depending on sort of marginalized versus less marginalized women, or whether in a low resource setting, you don't face, obviously the different kinds of ways in which you could see disparities arising vary a lot depending on the context, but I would imagine there still is heterogeneity in terms of the outcomes for women and the success of these kinds of interventions, and the way that those developing and implementing the interventions are seeing them. And so I guess my first question is just whether from just passing comments or information that was gathered by various points of this data collection, you noticed if effects seem to be fairly similar, or if there seem to be kind of heterogeneous treatment effects going on.
So with the qualitative, so definitely we found, I didn't present it here, but we did do some work like understanding the team's perspective and what helped them to do their work. Sometimes it did come up with lack of resources, that definitely came up, or being far from, some areas were more remote than others. So the teams might be having a large geographical area to cover. And lack of resources. So like with one of the quotes, they did point out that one of the barriers was lack of fuel, like maybe wanting to go do outreach, but not having the means to do so. So like with this type of intervention, The local health staff are determining what the barriers and solutions are, but they're not getting any resources. So, if they identify, well, we really need like a vehicle to be able to really get out to some of the remote communities. The project wasn't giving resources. It was focused on training, so that would still be a barrier. But it did come up, particularly geographical area, and different, sometimes cultural issues would come up, but the teams would try to work with the communities on those cultural issues. Like I mentioned, the postnatal care, the home visits were acceptable, but leaving the home to go to the facility was not. But the home visits were a nice solution. So those were kind of like things that we uncovered from the qualitative research. And a lot of the North, it was very rural areas that the teams were working in. So in some ways they were similar. I didn't present a lot of the findings from the South of Ghana, which has, lower maternal mortality and lower under 5 mortality and higher socioeconomic development. So maybe I should have presented some of those findings, because maybe some of the differences would have come out a little more between north and south. Yeah.
That's really helpful. It looks like Cheryl has a follow-up.
Oh, yes.
Another question that comes to mind as you're talking, I know when we were looking across 4 of the districts in the North, there was enormous variability based on sort of the leadership within the district.
Oh, sure.
So
Yeah.
one of the questions that I had is if you were able to do any sub-analysis looking on whether there were certain districts that seemed to perform better than others, and if there's any way at all. I mean, I know all of this gets very dicey because in Ghana, nobody wants to point fingers at anybody else.
Yeah.
So there's that, but any differences?
That's a good question. I mean, we had the data to do it, but because this was a government, we had to. They wanted everything at the aggregate level, and I think part of it might be not to point fingers at maybe districts that weren't doing as well as other districts. So yeah, we worked with the government, making sure we're doing what they want, answering the questions that they want. So because we were evaluators, we couldn't always set the questions. We wanted to be respectful of what the implementing team wanted. So we weren't able to do it, though we had the data that we could have looked at districts separately. But that's a good question. Yeah.
Cheryl? I had an even more unhelpful question, but I think it's something that really just resonated with me. So you titled this talk and you talked about sort of how these things might work and what we could learn in a lower resource setting. But I was wondering if you had thoughts about translation of these findings into contexts that are much wealthier but still have really poor maternal and child health indicators like the United States. Whether there are any lessons to be learned from either information you gathered during the evaluation or structuring an evaluation like this. And there were all these different kinds of really good best practices, things like checklists and empowering nursing staff to start procedures, before and so forth. But I was just wondering if you had any speculation, and maybe that's more of a just let's all think about it kind of a question. But I just think that there are some really powerful lessons that we can all learn from each other, and it's not as if these don't apply in well-resourced settings.
That's true.
Well.
Yeah, definitely. And quality improvement methods also are being used in high-income countries. So there, some hospitals do use this type of training and approach. But I think there's a lot to be learned because we have a lot of inequities in maternal health in the United States, particularly between white women and non-white women, particularly Black women, have very high maternal mortality. So key things that I really like about this intervention is that it's really driven by people on the ground, and they're really, they're kind of, part of the quality improvement method is trying to listen to the beneficiaries, like engaging them, really thinking about what are their like what are your barriers in terms of providing high quality care, but what are their barriers also in being able to access care as well. So I think that definitely could apply in any setting. We often hear, studies show us that a lot of times providers in the United States are not really listening to women, especially Black women, when they're talking about what they're experiencing and potential complications. So that aspect of really listening to the patient, I think is really nice and important.
Yes, you're talking about your team saying, oh, it's not culturally appropriate to leave the home for postnatal care, but home visits are okay. It's a perfect example of saying, oh, okay, this doesn't work for you.
Yes, yeah. Like I think too often, like in global health, maybe particularly, you have interventions that maybe are working in high income countries and wanting to force them to work in different countries without listening to the people on the ground, and some minor adjustments would make a lot of sense. And I think postnatal visits, the home visits, are so nice because it's hard for any woman who just delivered to take her newborn out and go back to the health facility. I found it difficult. It wasn't easy to get out of the house. So that home visit seems very, very nice. Yeah. And I just wanted to point out, I was just thinking of something. The government of Ghana wanted us to use their data from their facilities. It was very important to them as a means to show that that people are using this data for evaluations. And so, the more you use data, you hope the quality of that data is going to improve, because people are not seeing, oh, we collect this data, but no one uses it. We'll see, oh, actually people are using this data. So that was very important for them, that we actually use this health information data that they were collecting on a monthly basis.
And to Barbara's earlier point, my understanding is that DIMS is expanding to allow for individual records.
Okay, well, that would be nice. Okay, yeah.
Again, I don't know how quickly that will roll out. I know it's happening in other countries, but my understanding is that the goal for DIMS is to go to an individual, more like a patient record model.
Okay.
So at some point, there would be the ability to link some of the variables. The other comment, just also to Barbara's comment, is, Ghana is one of those countries that's actually done pretty well in terms of the distance. And I think it's some ridiculously high percentage of women are within 5 kilometers of a health center. So they aim to do that by putting a district hospital in every single district and having all these community health posts. So in Ghana, distance to facility isn't quite the same as it would be elsewhere. That doesn't mean it's easy to get there all the times. And it doesn't mean that they're close to a district hospital, but there is a nearby facility usually.
Yeah, often the CHIPs, the health posts, and yeah, definitely.
Okay, well, thank you everybody for such a great discussion, and to Kavita for a really wonderful presentation. So I will wrap up here to leave some time for Kavita to meet with our pre-docs and postdocs. So I thank you all for joining, and we'll hope to see you in 2 weeks when we'll be joined by Trent Alexander from ICPSR. Thank you.
Okay, thanks so much, everyone. Thanks very much. And I appreciate all the nice questions. Thanks.
Okay, well, thank you again for your presentation. And we have a good group here, a mix of students from a variety of backgrounds. I think economics, public health, and sociology are all represented here. So I know some of you may have questions for Kavita, so I'll turn the floor over to our trainees.
Nice to see all of you. Are most of you taking classes or or probably some of you may be at different stages, dissertation phase or classes? Or...
I'm all about dissertation.
Okay, okay.
There's a few postdocs.
Oh, here. Postdocs too. Okay, great, okay.
If you don't mind, I'll go ahead and start, partially because sometimes I keep closing my video to listen, but so will help with the kid or something. Yeah, so again, thank you for a really interesting talk. I really like the mixed methods approach. So as I mentioned, I study economics. I'm working on some health economic studies in Mozambique right now with one of our PSC professors, Dean Young, looking at HIV/AIDS and some COVID related things. this is relevant, I promise. My wife has a master's in public health and also in epidemiology. And we often talk about how it's funny that I'm studying health economics, and the language that I use to talk about statistics and methods is so different than what she learned.
I know. Yeah.
Often they're the same thing, but we use different words. And so we have to keep talking back and forth. And then we're like, oh, you're doing this. And showing me like odds ratios for the low jet. And I'm like, yeah, just run an ordinary least square. Like, this didn't work like a different way, like the same topic. Right. So there's been a lot in the last 10 years, a big push toward health economics and randomization and looking in development at different interventions and their effectiveness. How do you think that burgeoning literature kind of fits in with your work? How do you see the connection between these two? Is there room for working together more? Yeah. Or do you think that this literature that I'm starting to become into is it off base from what the questions that should be being asked?
Oh, not at all.
Open-ended questions. I just kind of want to bring up that.
Yeah, I will say I work with economists all the time. So on this project in Ghana, we had an economist advising us on the time series analysis and the cost effectiveness analysis. And just in general, in a lot of my work, I work closely with health economists quite a bit, or development economists. It is interesting. Sometimes the language is a little different. And I find like people in different disciplines have methods they prefer and dislike. So I know if I go to someone for some advice who's a biostatistician, that person may really like these particular methods. But if I talk to someone who's an economist, they may prefer these methods. But in reality, either method maybe it could work just fine. So yeah, but definitely. So with the quantitative impact analysis, we weren't able to do any. We didn't have comparison facilities, but one part of the Ghana work was actual surveys, household surveys. I didn't present on that because it's just too much to present, but we actually randomized. We didn't randomize, but we were able to have comparison communities that weren't part of the intervention for that part of the project. So, and I've definitely been on projects where we, like cash transfer projects where randomization is very important to really get an understanding of the true impact of an intervention. So applying the techniques from economics to our public health evaluations is very important. When possible, like sometimes you find that it's hard to do because a project, sometimes I find I come in when a project has already started. So it's too late to do any randomization at that point, but you can still get comparison facilities. So sometimes, you work with what you can based on when you're invited to work on a project, you see what is feasible and what the implementing team, what are the questions that they want answered. But I find more and more we're working on inter or transdisciplinary teams, often bringing together people from different disciplines because they have expertise that's needed for the work. And you bring your expertise, but other people have their expertise, and different methods are needed to answer different questions.
Great, thank you so much.
Do we have other questions?
Hi, I had a question about the presentations of results, like in the communities that you're doing the research in. And so I was wondering, like, what are some approaches, one, to building relationships so that you can use data internationally, but also just in work with people on the ground who are doing the work, but also how some of your, I guess, what are some of your approaches to presenting the data in the countries in which you're conducting research?
That's a good question. So with both the Ghana and Ethiopia project, they were government projects. So we were invited to be external evaluators, but we would, analyze, share data with them, make corrections or look at different aspects that they asked us to. We've written quite a few publications, particularly for Ghana. In Ethiopia, we're still working on some. And some of them are led by like UNC, and some are led by people on the ground, but we work together on them. So it's a shared effort. And we make sure we have permission before we start working on any paper, and make sure it's a collaborative effort. We're going to have, like a lot of our papers have 10, 14 or so co-authors, both from the implementing and evaluation teams, and different people take the lead. So those are conversations that we have, who's going to lead these different papers. Because it's a government project, of course, we have to, make sure that they're comfortable with anything that's going to be published. So that's definitely a key part of our work. And I think it's really important in doing global work to involve people on the ground. And in publications, sometimes not everybody may have had training on how to write a peer-reviewed paper, but you can work with people and they may have the interest in doing so. So part of it may be you encourage or support them to take the lead on a paper. We feel like that's part of our work when we're working with our partners, whether it's our evaluation partner like the University of Ghana or the government as a partner. But that's a great question. It's really important.
Or anything else? Well, maybe you could just take a moment to tell us about how you got involved in doing international evaluation work in particular, and a little bit more about your focus on data quality and how you arrived at that set of interests.
Oh, sure. So I think when I was in grad school, I was at Hopkins. I thought I was going to do my dissertation focused on India. And then I had a classmate who had done a lot of work with Doctors Without Borders. And he was working on a project looking at forced migration in northern Uganda and southern Sudan. And he needed some help with it. And I was really fascinated by it. Really was excited to work with him on it. And so that became part of my dissertation. So I got to do field work in northern Uganda and southern Sudan and learned a lot, and then really just loved working in Africa. So then a lot of my work shifted to Africa just by chance. I think a lot of the outcomes that I'm interested within maternal and newborn health, a lot of them are hard to measure, and sometimes data quality are issues. So it just kind of came naturally based on my interest in reducing maternal mortality and improving newborn health. So that kind of flowed naturally. And then so sometimes things may change. Like, I don't know for all of you, if some of you are at different stages, but sometimes you find yourself getting very interested in like a new area or a new geographical area. And it's nice and it's natural, and all the methods you've learned in school, a lot of times you can translate them into different topics. So a lot of the skills that you're gaining, you can use to study different topics, which I think is really nice. And then I found in grad school, like you learn about different methods, but when I started working, I still need to use and apply new methods. So that doesn't stop. But I think in grad school, you really learn, you really learn how to think about methods, how to learn them, what do you need to know about them? And so that's helpful as you get into your careers, and you may still need to be learning new methods. And that's also why I reach out to other people in different fields like economists or biostatisticians who have maybe different or deeper knowledge of a method than I do, and collaborate with them on that.
Great, thank you. Okay, anything else? Okay, well, we're just about at 1:10, so we can wrap things up. And I'll thank you again, Kavita, for a really excellent presentation and discussion. I agree with Cheryl Moyer. This was an incredible compilation of data.
It was a lot of data. I don't know where you all are with your different dissertations or maybe postdocs, but sometimes after collecting all this data, there's this phase of putting it all together that can take a lot of time. It can be a little bit tedious, but it has to be done. Yeah.
We certainly, yeah, I mean, you've borne great fruit from it. So thank you for all of your efforts.
Thanks you all. Thanks for Paula, and nice to meet all of you. Thanks so much.
Good meeting you too. Thanks for joining.
Thanks. Bye-bye.
Bye.